Okay, let's start. Okay, so for the definition of epilepsy, first you should know the other names of epilepsy. So the other names they sometimes use as seizures or convulsions. Okay, these are the two names. So when to label a person has epilepsy, you should have some concept here. So either there should be a disturbance of motor function or sensation or behavior and consciousness. So if you take for example, in the brain, you should have two problems here. They should be either associated with some consciousness level problem or even the behavior problem. Okay. And in the limbs, that is, you should have some problem in the motor. Means maybe there is movement, tonic, clonic, okay, or some sensation issues, means they can't feel at that moment or something like that. So four things should be here: consciousness, behavior, motor, and sensation. And all the four things, either they can have just motor disturbance, means just you see only one hand is shaking, it's just motor disturbance, or can be associated with loss of consciousness as well. So what happened here, if sometimes only one, that means it is occurring in singly. Sometimes along with the motor disturbance you have loss of consciousness, then it becomes in combination. Okay. So it can be these four things you have to remember. A child should have problem in the consciousness or his behavior. This you can attribute to the level to the brain. Okay. Or there is some abnormal movements in the hands and also some abnormal sensations. So it can occur only like just movement of the hand, that will be only motor function, or association with the loss of consciousness or change in behavior. So it can be in combination. So these things should be there to label it as seizure or convulsion. Okay. So when do you call it as epilepsy? More than or equal to 2 unprovoked seizures occurring more than 24 hours apart. Okay. It should be an unprovoked. Unprovoked means what? You don't have any trigger. Suddenly it is happening. There is no provoking here. Okay. So it can be 2. Minimum it should be 2 or more than 2. So more than 2 unprovoked seizures occurring 24 hours apart, or it can be 1 unprovoked seizure and probability of future seizures in more than 60%. Okay. They can have 1 unprovoked seizure and also they can have further seizures. A diagnosis of epilepsy syndromes means along with just seizure, the epilepsy syndromes will have other features also to put them as epilepsy syndromes. Okay. Please take care of your mics. Next is the seizure type. The seizure type can be focal, general, or any other type. As we know, suppose only one hand is moving, it will be focal. And focal again has simple and complex partial seizures. So simple means there is no loss of consciousness. The consciousness level will be okay. So focal seizure plus some disturbance in the conscious level will be complex seizure. So it can be focal or generalized, what we know as generalized tonic-clonic seizure or any type seizure. You can know it by based on the history and also by the EEG. What is the presentation in EEG? Whether this you can put it as a focalized or generalized or any other type of seizures. One thing history will also give you, suppose the mother says that only one hand is moving and he's always conscious, it becomes a simple partial seizure. And or one part of the body is moving but there's disturbance in the level of consciousness, then it is complex partial seizure. Or whole body is moving with uprolling of the eyes and the child will be unconscious during this time, generalized tonic-clonic seizure. So the history and the EEG will help you to know what is the seizure type. try to categorize into one epilepsy syndrome. Usually they will come into one epilepsy syndrome. Okay. So this is the what you will do usually in history and assessment here. Okay. What do you do here? 1 minute. So here, detailed and accurate history of eyewitness. So always you should always know whenever you see a seizing child or you have to describe how the beginning started and how the middle and how the end of the episode. So whenever the mother is describing, you should always ask what he was doing before this episode, immediately before, what was the actions done by the child. If mother has noticed, that has to be asked. And also the episode itself, how it started, that is onset, then progression, how it was progressing in the middle, and also the end of the episode. So onset, before onset, what the child was doing, and how did it start, and how did it continue, and how did it end. So you will ask everything, beginning, middle, and end of the episode by the eyewitness. Usually eyewitness will be the mother or father, whoever was with him. So you should take a detailed and accurate history of eyewitness about what the child was doing before, and how did it begin, and how it progressed, and how did it end. So onset, progression, and also the duration, how long did it last, which we are usually doing in all: onset, duration, and progression. Then when history is unclear, you are not happy with the history, it is unclear to you, then you will advise them to record the episode in the mobile phone, or a camcorder can be very useful. So when they come to the visit, they can show you. Now, episodes occurring only in certain situations with certain provoking factors. So always in history, you have to take the history of provoking factors, very important. Episodes are not happening unprovoked. There are some provoking issues here. Episodes occurring only in certain situations like falls, emotions, and certain posture, etc., except for photosensitive stimuli, or are likely to be non-epileptic. That's why here in the definition, if you have observed, the word used is more than 2 unprovoked seizures occurring more than 24 hours. Usually they should be unprovoked episodes. They should not be provoking, except the photosensitive stimuli. Okay. So like provoking, like he's always having this after he falls down, or there is some emotional disturbance to him, you have to think that this is not epilepsy. This may be just a pseudo seizure or something. Except for photosensitive stimuli, all other usually epilepsy will be unprovoked, not from the provoking factors. So any provoking factors, history will give you the clue. Any underlying problem, yes, the underlying developmental issues with the child may be a genetic condition. So the underlying problems like learning difficulties, cerebral palsy, hypoxic ischemic encephalopathy, head injury. So history of trauma is very important in any epilepsy or seizure child presenting to you, and any other CNS insult. So learning difficulties can be, maybe a child has genetic problem, so you have to ask for that. And cerebral palsy due to hypoxic ischemic insults during the birth, and head injury, and any other CNS insults like some acute trauma or acute infections, meningitis, encephalitis, which had provoked. Okay. So look for any comorbidities as well. Then family history may be positive in certain idiopathic generalized epilepsies. They can run in families. Okay, some generalized epilepsies. So family history. Some symptomatic epilepsies, like tuberous sclerosis. So here comes the importance of neurocutaneous stigmata. So always ask for any skin changes, hyperpigmented patches in the skin or hypopigmented patches in the skin. Okay, so means hyperpigmented. Here he has given neurocutaneous syndromes, cafe au lait spots. Depigmented patches will be what we call these patches in tuberous sclerosis, the depigmented patches.
Ash leaf.
Yeah, ash leaf. Yeah, ash leaf patches. This you use wood slide for that. So the cafe au lait and ash leaf patches. Then so tuberous sclerosis, searching for the neurocutaneous stigmata is very important, and autosomal dominant frontal epilepsies. So in the family history, the neurocutaneous syndromes will run in families, and certain idiopathic generalized epilepsies, and also some dominant frontal epilepsies.
However,
okay, next is the neurological examination. So in the examination part, you will tell, I will do the complete CNS examination to look for any weakness in any part of the body or any numbness or any facial palsy or any thing, gait abnormalities, anything related to complete neurological examination has to be done in these children. Very important. And neurological, and always searching in the skin if you have anything which can help you. If in doubt about diagnosis, do not label as epilepsy, but watch and wait or refer to specialist. So if there is no clear, as we said here before, again, if there is unclear, you will ask them to record, and still you are not clear, you will not label them an epilepsy. You will watch and wait or refer to specialist. So here he has given very clearly the diagnosis of epilepsy is clinical. So if anyone asks you the question, how do you diagnose epilepsy? Just say clinical. Okay, by your history, what the mother gives, and if it is very clearly and describing, yes, you can consider. At the same time, they can get you a recording in the phone of the episode. Okay, and usually the description will be unprovoked. Okay, except some features of aura they may feel, like this photosensitive stimuli can be an aura, but there won't be provoking factors like falls or emotions. Okay, it will come suddenly. They feel something and they start, but no provoking factors. Don't confuse between provoking factors and aura. Okay, don't get confused with that. Next, for the genetic conditions, you'll ask for the family history and neurocutaneous stigmata. You will search in your examination also, asking and searching both, and complete neurological examination for gait abnormalities, weakness, and also any numbness or sensation abnormalities. Okay, and trauma also, history very important, and diagnosis is always clinical. If you are doubt, you will wait and watch, or you will refer to the specialist. So now next is the seizure types. So these are the seizures today we will see. One is the tonic clonic seizures, then clonic, then atonic, then absence. Absence, you have typical absence. Okay, absence with special features such as myoclonic absence or eyelid myoclonia or atypical absences. So typical absence is just staring look. Okay, atypical absence may be something associated with it, or they may have like myoclonic myoclonic epilepsy along with the absence, or eyelid myoclonia, means continuous blinking of the eyelid. I think this one. Okay, then in myoclonic, you have myoclonic and myoclonic atonic can be together. Next is focal characterized by more than one of the following features. Okay, they will have aura. So these are the, first is the generalized, these are the generalized seizures. You can have all the body involving tonic, clonic, clonic, atonic, absence, and myoclonic. Okay, then focal will be aura. They are characterized by more than one of the following features. They can have aura, and also it can be motor, it can be autonomic, and also awareness and responsiveness can be altered or retained. As I told you, they can be conscious or they can be unconscious or altered level of consciousness. Okay, may evolve to bilateral convulsive seizures, and sometimes initially focal, they may become later generalized. Then unknown epileptic spasm. Other causes for this epilepsies will be genetic, metabolic, or even unknown, idiopathic. Okay. So now enough. If we read too much, it will not be interesting session. So I will show you one video now. I need one volunteer. I need one candidate, please.
Okay, can I do? I do.
Okay, no problem. So I will show you the video, and after the video, you will describe the video first. Then you will tell as you do in the video station. You will tell me what history you want to take, and what examination, and your
Okay.
differential, and investigation and management. So later we will read from this investigation management also. Okay.
Okay.
3, 4, 2, 2, 3, 4, 3, 2, 3, 4, 4, 2, 3, 4, 5, 2, 3, 4, 6, 2, 3. The ending. Why are you all coming up? Following me. 5, 6, 7, 8. 1, 2, 3, 4, 2, 2, 3, 4, 3, 2, 3, 4, 4, 2, 3, 4.
Is she shaking like that? What's she doing?
You just move back a little bit, please.
She's still shaking.
Right, Sarah, can you go and get Mr. Bosworth for me? Joanne, can I have your jumper? Hi, Molly. It's Miss Sharp. We're in the gym. You're okay, but you've had one of your seizures. You're going to be just fine. All right, I just need you to relax. Try your best to rest. Good girl, that's right. You're doing really well. Try your best to relax. Can you just go and wait in the 2, 3, 4, 4, 2, 3, 4.
Is she shaking like that? What's she doing?
You just move back a little bit, please.
She's still shaking.
Right, Sarah, can you go and get Mr. Bosworth for me? Joanne, can I have your jumper? Can you just go and wait in the corner for me over there?
Okay, so let's start. 1 minute. Okay, you can start now.
Yeah, I have seen teenager in a gym setting develop a sudden onset of fall associated with the generalized clonic movement associated with the tonic posturing, steering of the gaze.
Okay.
And then she developed a post-ictal drowsiness, and then teacher make neck flex, maintain the airway, and then she put him left lateral position and flex her legs, and then after the seizure has been set.
Okay, and also she noted the time of the seizure. Okay. So what history you want to take in this case?
In this case, I want to see want to take the history about the incident before the event, during the event, and after the event. I want to take history of onset, duration, any fever, any vomiting, any headache, any urine and fecal incontinence, any skin spots on the body, any rashes on the body, any symptoms of flu, cough, shortness of breath.
Okay.
And in examination, I want to do a neurological neurological examination, including Glasgow Coma scale, and also the eye and fundoscopy. And then I want to to find out any focus and the signs of meningeal irritation.
Okay. Okay, a complete CNS examination. You want to do the Glasgow Coma scale and BP and fundoscopy. What else?
Yes, yes. And take the abdominal examination for any renal scar, for any renal transplant.
Okay, then tell me about your differential diagnosis here.
Here she has generalized tonic-clonic epilepsy of primary pathology. It could be due to raised intracranial, any brain tumor,
Okay,
and
occupying.
it could be a febrile seizure.
Okay.
And then, okay, just give me 1 minute. I think Azan is on.
Okay, yeah, we can stop now. 1 minute, no problem. Okay, let's continue. So start from your differentials.
Yeah, first of all, it could be a case of primary epilepsy.
Epilepsy, okay.
Then could be a case of meningoencephalitis. Third could be a case of space occupying lesion, and fourth could be a case of hypertensive encephalopathy. Yeah, this press, we can say posterior reversible encephalopathy.
Okay, so give the three most common. So we will consider primary epilepsy.
Epilepsy, meningoencephalitis, and space
Okay,
occupying.
okay, next. So tell your what investigations you want to do in this patient.
Yeah, I will.
If this is primary epilepsy syndrome, what investigation you want to do?
First of all, I want to take blood glucose level, and then I will do urea electrolyte and calcium phosphate, the bone profile, and third I will do this electroencephalogram and
EEG, okay.
EEG, and then I need a history regarding for CS lumbar puncture or MRI brain.
Okay,
Actually,
this is primary. No,
Yeah.
my question was if this was primary epilepsy syndrome, do you consider CT brain here, MRI or CT brain?
If it is first episode, we can proceed.
if by history, if by history and your examination finding, the child outside the epilepsy has no neurological findings, normal, still you consider city brain here?
Because here I don't know the time. If it is status epilepticus, then we can proceed with MRI. If it is a simple seizure, just like because I don't know the duration, so I cannot label it. So if it is not status epilepticus, then we cannot proceed. But if
No, the question is primary epilepsy syndrome. So usually in primary epilepsy syndrome is they are recovering fast. It's simple.
yeah. So
So
in
that means
primary,
you will
there is no
not-
need. No
you
need.
will not go. If the
Yeah, yeah.
question here is you will not go, you will you will involve your consultant and you will start the anti-epileptic medications will be started and the child will be observed. So when do you refer this child to, so this is a primary epilepsy syndrome and you involved your consultant and anti-epileptic drug is started. When do you refer this child to the neurologist or tertiary center?
If first indication status epilepticus, any focal deficit, Glasgow Coma scale less than 8, and any suspicion of any infection, raise ICP.
Okay. Okay.
And any metabolic disorder.
Behavioral changes will also, any features of increased intracranial hypertension, as you said, and any focal seizure, and no improvement with your treatment. The child is not showing any response after 1 year or 2 years, still they have seizures. Okay.
Okay.
There are indications for MRI, which we should know. And also there are indications for referral to the tertiary center. That also we should know. Now we will go through these things because the question came up before we go to the next video. Okay. Okay. See here, I was asking about primary epilepsy syndrome. So usually for the primary epilepsy, which is very clear to you, you will not go for MRI. So what is the indication for MRI here? He has given focal epilepsy. Okay, except Rolandic seizures. So Rolandic seizures, always remember, you will not consider MRI. What is TLE here? Can someone tell? Temporal lobe epilepsy? Maybe.
Yeah, temporal lobe epilepsy.
Yeah, I think.
Okay, focal epilepsy, including temporal lobe epilepsy, you will go, except for the clear Rolandic seizures. And also any epilepsy in children, say, so if the child's age, this was a teenager, it was clear for all. If the child's age is less than 2 years, any epilepsy you will go. Okay. Then myoclonic epilepsy, you will go. Loss of previous good control means the child was in good control. Suddenly he has started seizures now. Then in such a case, even in primary epilepsy syndrome, maybe he had good control with drugs, but there is loss of control now. You will consider. Seizures continuing in spite of first line medication. First line medication treatment is given to the child, still he is, that means you can say simply as failure of your treatment, failure of the first line medication. And or there is neurological deficits on examination or sudden appearance of new neurological signs, developmental regression in children with epilepsy, infantile spasms. Okay, so always for if the diagnosis is given to you as primary epilepsy syndrome and ask this question, say clearly it is no. You will go only if there is failure of first line medication or there is loss of previous good control. Okay, these two only you will tell for primary epilepsy. To start with, you will not go. So all focal epilepsies you will consider, and extreme of age, remember as extreme of age, like epilepsy less than 2 years. Then in myoclonic epilepsy, can someone tell me what do you mean by interactable seizures?
Yeah, Fatima Nura.
Who is with me? Dr. Muhammad Khalifa. Okay, welcome. Tell me.
Yeah. Usually, interactable epilepsy, it was meant if the patient is like drug resistant, and drug resistant means like being into anti-epileptic medication or more, basically. Sometimes it might be told for the patient having like polymorphic type of seizure, which is mean more than two type of seizure. يعني in a simple way يعني.
Yeah, I got your point. Like the
Okay.
refractory seizures, what happens in tuberous sclerosis usually? The
Same
children,
like same like to link it with the other like developmental when it comes to global or single or global developmental delay or just like isolated also being like two domains or more. And try to link it to help us all together. Okay.
yeah, I got your point. I know interactable seizures, usually we see this in Strach-Weber syndrome, where the child will be on more than 2 medications and no response usually, and also in tuberous sclerosis. Okay, so now the next question to him, what was the question I asked about? This was the indication of MRI. Yeah.
Sorry, intractable seizure, how many failure of medication?
I think you can remember it as refractory seizures. That means they are not responding to your medications.
That means how many medication? 1, 2, 3, 4.
Maybe more than 2. Just go back and check. I don't know. If Dr. Muhammad Khalifa can tell, it's okay.
Okay. It's written 3 here.
Where?
In the Google.
Okay, no problem.
Now, when the 4th comes, you label it as intractable. That means we have used 3, not responding, and now we are going for 4. We label it as intractable seizure.
Okay, and one more question I had asked you about tertiary referral, right? Referral to tertiary center.
Yeah.
This is also there here. Let me see. This you should know. Further opinion and referral to specialist service or tertiary center. When do you do? Refer immediately. Behavioral or developmental regression. You see there is developmental regression, immediately you'll refer. Epilepsy syndrome cannot be identified. The way child is presenting to you is not clear to you. Well, that was given even in the history. If it is unclear and you don't want to put it clinically as an epilepsy, you will refer to specialist, okay? Because it's not clear to you. Epilepsy syndrome cannot be identified. This is immediately. There is something called soon and there's something called just refer. Refer soon. Again, remember about the extremity of age always, okay? Age less than 2 years. They said even he's presenting with tonic clonic seizure, clear like primary epilepsy with no neurological deficit, still you will refer and you will also do MRI in this case, child age less than 2 years. Okay. And seizure continuing despite anti-epileptic treatment for 2 years. You give anti-epileptic treatment and 2 years he is still having seizures. 2 AEDs have been tried and unsuccessful. Okay, this is one criteria on anti-epileptic drugs for 2 years. And also you have already tried 2 anti-epileptic drugs and he is unsuccessful. Risk of unacceptable side effects of medication. Your first line drugs are not tolerated by him. He has side effects. Okay. And any structural lesion. Suppose you did CT brain in a child and you saw any structural lesion. Okay. Then psychological and psychiatric comorbidities they have. Diagnostic doubt. Always remember this. You will refer when you have diagnostic doubt. So if this is asked, at least I think everything will have some 7 points. we can, at least we should be able to answer 3, 4 at that moment. So see to it that you remember the most favorable and important points which you can answer. Okay, now we will go to the next video. 2 or more anti-epileptic drugs will be labeled as refractory seizures or intractable. Okay. So I want to give some only few points, and also others can also give. I think in the history, I don't know if we asked about history of trauma. Okay. Always we will keep here like this for both for history and examination and differential diagnosis in CNS cases. Tumor, trauma, and infection. Okay, ask questions related to this apart from your primary. As you said, 1 minute, stop share. So here what, as you said, first description of the episode, onset, before onset, what he was doing. So you will know about the provoking factors, or it was an unprovoked. And also you can ask feeling of something which he really has to know about the aura. This is the before onset. Then how did it started? Then how did it progress and how did it end? Okay. After finishing about this, you will concentrate on your differentials. Okay, so your differentials always in CNS case will be tumor, trauma, and infection. So related to tumor, you should ask about the behavioral and signs of increased intracranial hypertension, like headache, vomiting, or blurring of vision, something like this, visual complaints, and tumor, and also they will have behavioral abnormalities. Okay. Then trauma, any history of fall down or severe injury to the head, and infection, any fever. Okay, this is finished. Okay, very important. And also, as I told you, any skin spots or any family history of epilepsy. This is my thing in the quick this for your differentials. So if I missed anything, please anyone can add. Anything?
Dr. Cruz?
Yeah.
We can add drugs and toxins at this age if it is a teenager.
Yeah, sure. Very good point. Yeah. So also any drugs she is taking or any medications. Yes, very good. Anything else? So here we can add in our differentials tumor, trauma, infection, and also drugs. Okay, you can make it like that. So after,
Doctor, sorry, can you give the example of the drug which can lead to such type of epilepsy?
I don't know really.
Because the examiner may ask in case like what are the drugs which can cause such epilepsy?
I don't know. If the one who told me can add, I will be grateful. Then apart from that, so be careful. If you are afraid, don't say. This is the common, always keep tumor, trauma, infection in your mind. Apart from the primary epilepsy.
Maybe if taking insulin or oral hypoglycemic agents may cause hypoglycemia and seizure. This is one of the examples.
Yeah, oral hypoglycemic. Yeah. And this
alcohol also, Dr. Noor, alcohol. Teenagers with alcohol, they will increase the seizure, you know. That's why there is a counseling station, na, alcohol.
Oh, yeah, very good. So main here, don't forget about these 3 things, tumor, trauma, infection, and any skin spots, and family history. Very important. Okay, family history of similar problems like this. And also if you consider any CVS like syncope as your differential or something, you will tell less likely, because here the picture was very clear of the tonic clonic movement. So you can ask even history of sudden deaths in the family, but don't complicate, because it will be just 3 minutes, 6 minutes for you. You have to cover history, you have to cover. So keep these things in your mind. It is more than enough, as long as it is clear for you that it's a tonic clonic seizure. Okay, so about the tumor, that is the related symptoms, trauma, about the infection, any fever, recent onset of fever, and even the infection will cover all these: headache, vomiting, blurring of vision, everything will be covered even in infection. Any skin spots they have, any similar condition is running in the family. Okay. Then for the examination, you will do complete CNS examination to look for any weakness, any loss of sensations, okay, any gait abnormalities, all these things, and about the consciousness level of the child. Okay, this is the examination. Other examinations, if you want, you can do the cardiovascular examination if your differential is syncope or something. Okay, so these two examinations, and also the skin examination for the neurocutaneous stigmata. Okay, so any others you want to add? Any eye examinations or anything you can add here? If you want, you can add vision also, you know, because tumor examination of vision, fundoscopy in cases of tumor becomes very important. So many you can put. Then after examination, your differential diagnosis. Differential diagnosis was okay. So it was a generalized tonic-clonic seizure. And again, as here, you will consider again tumor, trauma, infection. So you will consider space occupying lesion, any fever. So you will consider any meningitis, encephalitis, and also any trauma can be considered. Give common. I don't know, we will go for press here. Don't, I think it will be a complicated. For I am thinking like that. Okay. Any comments for this? Any other differentials you want to add? Okay, if there, we will go. Otherwise, we will start with investigations now. Okay, for the investigations, some bedside. Now, suppose in the acute presentations, definitely you will do some bedside investigations. What you want to do? Bedside. Blood glucose is very important. Blood glucose, blood pressure, and fundoscopy. Okay, these three becomes a part of the bedside examinations. Then rightly said by Dr. Yasser, CBC, urea electrolytes, and also bone profile you can do. For this means mainly electrolyte disturbances, then EEG you will consider in this case, if this is primary epilepsy. If you are thinking of any other, like this features of tumor, increased intracranial pressure, and also features of infection, like she has fever and all those things, you will also consider CT and MRI here. Then the management. If it is primary epilepsy syndrome, your consultant himself can, as long as he is clear, clinical diagnosis, and with the support of EEG, he can start on the anti-epileptic medications. Then we discussed about the referral. When do we want to refer? Okay, so we will go to the next case. If there are any comments, you can give before we go. Okay, no comments. So drugs, remember what they said very nicely, any hypoglycemic drugs they are taking. So any poisoning can also be cause here, drug overdose, and also alcohol. Okay, so who want to do the next?
Can I do, doctor?
Sure, you can do, no problem. Because most of the answers we already discussed, so it's just for practice. Okay.
Oh, okay.
So,
I can sit.
So you can see the video now and then we will discuss.
Teddy bear, turn around. Teddy bear, touch the ground. Teddy bear, show your shoe. Teddy bear, that will do. It's Nina. No, it isn't. Yeah, it is. It's in the alphabet. Next is B for Beth. Me. No, it's oldest and I'm the second oldest after Adele. Isn't that right, Adele? My birthday's after yours. Yeah? Am I not next? No, you sure said you were chasing Jack Garrett. With the rope, Ted. I had a little puppy, his name was Tiny Tim. You're out, my turn. I still was not out, it wasn't me. It was Katie. What? It was you. You stopped the rope. Sorry, I didn't mean to. Right, I'm still in. I had a little puppy, his name was Tiny Tim. Katie, why do you keep stopping the rope? Come on then, Katie, give me the rope. So not fair.
Are you okay, Katie?
She keeps stopping the rope, but it's my turn.
It's okay, Sally. Are you okay, Katie?
I'm fine, sir.
Okay, carry on, girls.
Thanks, come. Teddy bear, touch the ground. Teddy bear, turn around. Teddy bear, touch the ground. Teddy bear, show your shoe. Teddy bear, that will do. It's Nina. No, it isn't. Yeah, it is. It's in the alphabet. Next is B for Beth. Me. No, it's oldest and I'm the second oldest after Adele. Isn't that right, Adele? My birthday's after yours. Yeah? I had a little puppy. His name was Tiny Tim. You're out, my turn. I still was not out. It wasn't me. It was Kate.
So is it clear to you?
Yes, doctor.
Okay. We will start or you want some time?
Give me 1 minute only, please.
Okay.
Okay, doctor, I can start.
Okay. So you start now. Describe the what you are seeing the scene.
Okay. In the scene, I saw the group of children. They are playing in a school. They are wearing out of them one girl, which is of average height and build, and average height and build, teenage girl. She's suddenly having a blinking of eye and suddenly stopping the activity with no loss of consciousness, and these movements are of brief duration, and spontaneously recovery is there.
Yes, brief duration with loss of consciousness and spontaneous recovery. Okay.
Yeah, okay. So what else? Like.
Okay, finish. So your description finished. So how many times you saw the attack in the video?
Okay. I sorry, I could not count, but there are multiple episodes happened. 5 to more than 5 episodes at least. There's 5 or more.
Okay. So what is your history?
On
What
this,
you want to take?
on the history, I will ask about. I will ask about the history of this. First of all, I will take the history before onset, during duration, and what happened before, what she was doing exactly, and how much time it will take to finish that episode, and how much time she will take for the full recovery. After that, I will take the history of any regression of the milestone. I will take the history of any delays or learning difficulties. Any family history is also important, and history of the fever and history of the trauma also I am going to take.
Okay, then examination.
On examination, I will perform the full neurological examination in terms of his gait, in terms of his learning develop, in terms of his any focal sign, any cranial nerves I would like to examine. I will check the eye for the papilla edema, cranial nerve, any loss of weakness over the body. Beside that, I would like to do this examination. I will do the developmental assessment of this child as well.
Okay, yes, developmental assessment. Okay, then what is the differential diagnosis you want to give here?
On the top, I will make the diagnosis of absence, juvenile absence epilepsy.
Absence
And
here. Okay, then
absence, then it put, this is my only, and it, this is the only differential I can make because of, it is very typical of the absence, the way child present.
okay, but absence can also be sometimes associated with what?
With juvenile
Typical absence. This you will put your top of differential here as typical absence, but sometimes they can also present with some myoclonic absence. So all absences you can put here as your differentials, still negating them. To say myoclonic absence, you don't see any myoclonic association with it, or any eyelid myoclonia, and also any features of atypical. You can say and you can negate it. Okay. So what your investigation?
In the differential daydreaming, you can put as a differential for absent seizures.
Yeah, daydreaming.
Okay. Okay.
Okay. Anyone want to suggest any other differentials? Can go ahead.
Also selective mutism. We can put it in our differential diagnosis. But selective mutism, it will be all times.
Yeah, all time mute, not like this girl is playing very nicely and suddenly she'll be out.
Yes.
Okay, so you can say, but you have to negate it, telling that less likely, very less likely here. Okay, so tell about your investigations and management for this case.
For this case, I would like to perform the EEG, because EEG is a diagnostic, and that could be that is specifically showing the 3 per second spikes and wave pattern, which is typical for the absence seizure.
Okay.
I will this EEG will be the diagnostic in her case.
EEG is the diagnostic. Okay. Any other things you want to do, or how do you want to manage her now? What is the management plan now?
I will involve my consultant, and after EEG, which is clear cut and showing that it is absence epilepsy, I will proceed for the medicine ethosuximide for this child.
Okay. Okay, so consider. So this will come under primary epilepsy or no?
Yeah, this is a primary epilepsy.
So you will consider CT brain here?
No, I will not go for the CT or CT or MRI brain, because child is teenage, and I will it is not the focal epilepsy, it is the generalized epilepsy. I'm confused.
Okay, ethosuximide is your choice of drug.
Yes.
Okay. Any other first line drugs you know?
Yes, we can go for the valproic acid, but as she is a female, so we will avoid, better to avoid in these teenage girls.
Okay, so others can give your inputs now. Anything you want to add in the investigations here? She told EEG only. EEG is diagnostic.
Yes, doctor. I did not tell you the other, CBC, etc., because I did not keep in my differential infection trauma. So, and that is why I did not mention about the MRI brain. That is the reason. And EEG, because this is typical, and if EEG is not conclusive, then I can think of some other, then EEG will tell us so many things. So EEG is my investigation of choice in that case.
Someone is writing hyperventilation test.
Yes, hyperventilation will exaggerate the if EEG is abnormal, hyperventilation can increase the this EEG spikes and wave. If we'll do the hyperventilation, the EEG will be showing these 3 spikes, 3 per second spikes and wave pattern.
Okay.
So we have to perform EEG while doing the hyperventilation. It is like that.
Okay, great. So clearly be clear, as long as you label her under the primary epilepsy, you are not seeing. So when do you label her now? As you said, she is presenting to you. Typically, the video what you saw is giving you the indication that she is absence epilepsy, right?
Yes.
So what you will do now? You will consider here EEG. Who will do? Usually neurologist or the pediatric consultant. What is it in the UK? If anyone here can tell us. I think the pediatrician can do it, right? Because usually for primary epilepsies, they are not referring to the neurologist, is it?
No, I don't know.
Yeah, we have to check this actually.
But I think so because the video is only for diagnosis.
Just open your mic now. Okay.
Yeah, I think for diagnosis, video is the only thing, but we have to tell each and everything while in discussion, because if we see EEG, only this EEG, and we can do this at it's difficult to finish the time.
Yeah, you can say that you will involve your consultant and consider the treatment. And also you can say that if the treatment fails, she needs referral, like all those things you can say.
Yeah, because means
You can
we
say
have
that
to.
I will start with the first line management. And sometimes what happens, the child may start with absence epilepsy, but they can go into secondary generalized also, which is not shown to you in the video now. But sometimes over a period of time also this can happen. So any development of new epilepsy or any new neurological signs, so this child needs follow up to see the response to the anti-epileptic medications, whether she's out of it or not, like this. But since it is very clear, I don't know, like this fever, meningitis, all these things, I don't think they will present like typical absence seizures, even the trauma.
These are only till differential, and but the investigations and this one the management, we have to discuss the epilepsy, the whole general approach, you can say.
Yeah, we can start like EEG is the diagnostic. This is the three spike and wave pattern.
This is specific. Then we go for supportive. We can do just like glucose. We can do bone profile to see any electrolyte disturbance, just like this one.
Yeah, and developmental assessment also is very important here.
Yeah.
Always developmental assessment and involvement of multidisciplinary developmental team. And if the team is asked, you can also consider neurologist also along with the pediatrician and the entire developmental team. You don't know about the developmental status of the child. Okay. So anyone wants to give any comments on absence epilepsy?
Dr. Noor, I didn't reach hear this actually because I was just in the break. I don't know anything peculiar other than what I know for it. I hear like the last comment as if you have been commented about atypicality or something like that of the absence.
Yeah. Tell about this three forms he has mentioned here in the absence. If we go here, he has mentioned.
Yeah, typical, myoclonic, and atypical absence.
Yeah, like this typical absence. This was what we showed was typical absence, but they can also present with special features such as myoclonic absence or eyelid myoclonia. I think eyelid myoclonia means continuous blinking of eyes, right?
I think so. Which is like honestly not really common, but which is very common, which is the typical one, which is usually usually it will become like easy to be described like sudden onset and sudden offset. And usually it might be just like 10 to 15 seconds typically, or 20 seconds on duration. And this is why it is during the absence itself, they will become total loss of consciousness. This is why it's classified under the generalized type of epilepsy. And hyperventilation test, it might help you in the clinic if you will do it. Most of the time you might find it like positive in 85% of cases.
EEG will show you the positive spikes if
I
you
mean,
do
I
with
mean,
hyperventilation.
I mean the hyperventilation itself. If you will do it in front of you clinically, you will most of in 85% or near 90%, they may have like the staring or the absence in front of you. Also, it become like easy bedside test that you can do it if you don't have the facility to do any EEG. And the EEG, all of us we know it is like typical 3 Hz.
Yeah, this
And for
typical
the-
3 per second spike and wave, you can see even if the child is not in the, means when you're doing this EEG, she is not in the absence seizure state. She's normal. Still, you can
Sure,
see this.
sure, you are right. Very good question. Most of the EEGs that being done for the patient, it become like interictal EEG, which is mean you are doing it in between the seizures. And most of the findings that seen in the reported EEGs all over the world, you will find it like interictal. It means not ictal EEG. In ictal EEG, this is the best quality and test to do it for epilepsy patient, if ever. You will do, this is the best. But it is not applicable anywhere, even in a very high setting, not easily. It will be done in certain criteria, certain indication. But overall, you are right. If the patient is like good control, good compliance, you might not find, or you will find, there is like different talk about that. Sometimes they'll become very active. You can comment very abundant which like seen in every second or in how many minutes in the minutes you will see how many activity, or sometimes they are telling it is like only occasional. After any few days you might see just like epileptic activity you see, or you can comment it like rarely seen. That means indicate there is like a spectrum of finding of the EEG for the same patient during his the journey of his management or the treatment. But the other thing is the atypical absence also. I felt it's like important also to all of us to have something to know about it a bit. For the like some patient, for example, one example is GMA,
Juvenile
juvenile
Myoclonic
epilepsy.
Epilepsy.
It might started in the early childhood with like kind of absence, but when the patient reaching like a teenager period, they may start to have other type of seizure, which is like GTC, I mean, generalized chronic, as well as the absence altogether. This is one like example, and this is why it might become kind of very nasty type of seizure. Why most of the patient will be like on medication for life, because they will behave like clinically and at the level of neurophysiology also bad, unless kept in this medication for a very lengthy period during their life.
Okay. So now, so sometimes even normally also the child is normal. Presently, she's not ictal. Still, we can get 3 per second spike and wave.
Yeah.
And if we ask them to hyperventilate, these waves can become more prominent.
More prominent, and also one of the things that will be done, like in GMA, for example, one example, one of the triggers, or that you need to do it during your recording EEG, to do like photic stimulation. This one, it will be done by the machine or by the one who is performing the EEG himself as a technician. This will become like augmenting the epileptic activity that will appear clinically and in the EEG itself, which has been called electroclinical. That means electro, it means will be seen in the EEG, and clinical in front of you. So electroclinical correlation.
That means you're giving some photosensitive stimuli there, so that the child can.
To see that, to see that is how good he is controlled. Because if he is controlled enough, that means even the trigger, like your trigger, which is photo sensitive or photic stimulation, might not affect him. That means he's being like really covered well and in a good state of control.
Okay, inshallah, very good points. Alhamdulillah.
One last issue, but also it's like important. Not only atypical absence, just will be. You might see it in another types of with other atypicality, not only like supposed to be absence and GTC. You might find it with other kind of any type of seizure, but mostly the GTC, or it can be with let us say like other focal lesion like lip smacking, as we have used to have it in the Mrcpch videos, probably, isn't it?
Yeah, they can have this lip smacking and all. Yeah.
And focal type. Thank you.
Okay, thank you so much, doctor. Nice information. So here, so in absence, you should know two things: common childhood and adolescent absence epilepsy. Okay. So here, when do you label it as childhood? Depending upon the age of the child, 3 to 8 years. So for adolescents, juvenile, it will be 9 to 10 years. So this child, she can be 8 years or she can be 9 years as well. So you can just give an average age if age is not given to you. So more common in girls. This is very important. Several up to 100 brief episodes in a day. So you see in the video, so many episodes she had in a short period of time. She was standing, then she was rotating the rope. She had maybe 2 to 3. So for me, I think I noticed up to 3. Then that teacher came and he was telling, then what happened, I don't know. I did not play the video much. So you can remember several up to 100 brief episodes in a day, very quick recovery. So quickly it happens and recovery will also be very quick. So typical EEG 3 per second, 3 per second spike and wave. 10 to 30% of children with this condition have generalized seizures in teenage years. So we call it as primary absence with secondary generalization also. Okay. Again, 3 to 8 years of age, more common in girls. Up to 100 brief episodes they can have, very quick recovery, 3 per second spike and wave EEG pattern, 10 to 30% of children. So you can remember 30%, 1/3 almost of them will with this condition can have when they grow, or when they grow old teenagers, they can have generalized seizures. So now in juvenile, what happens? Absence frequency is less than in childhood absence. See here, he said up to 100. So this frequency will be reduced in juvenile, is less than in childhood absence epilepsy. Cluster of awakening, cluster of after awakening. Okay, they can have in clusters also. After they wake up from the school, they can have clusters of seizures. 90% of children with this condition have generalized seizures in the same period while they have absences. Okay, so they can have in this commonly happens in teenagers. Okay, remember this commonly happens in teenagers because he gave that they can go into generalized seizures in teenage years. So 90% of them will have absence and generalized seizure together in the same period while they have absences. So EEG, generalized spike and wave. So here it will be clear 3 per second spike and wave. But here, since they can have generalized seizures and the absences together, they can have EEG and generalized spike and wave. Okay, I want to ask one more question. Can some patients have to start with absence, that is the staring look, and then they will go into generalized? Does this happens always, or it can happen like this and also simultaneously?
As far as I know, it can happen. And good example for that itself, GMA.
So in JME, they can start with absence and then proceed with myoclonic epilepsy.
Yeah, and one nice comment I heard it from one also neurologist telling that anything brain can do can become a seizure, because not only the things that written in the books that usually it has to, because there is like many types of abnormal moves become like really astonishing, and lately with very careful study it might be like a seizure.
Okay, so we finished with 2. So now we will go for the third one. Then after the third one, we will take short break for 20 minutes for the prayer, and then we will continue again. Okay, so that we will finish most of the epilepsies today. Okay, so I will play the video now.
I'm not sure if it's a mayfly or a mozzie.
Look at the antenna.
And
The tail, you muppet.
can't be bothered.
Give it here then. You write it down this time. What's wrong with you?
I'm just tired.
It's last lesson. Get this over with in its own time.
Okay.
A 3. Jacob, what are you doing? It's gone all over the sheet.
It's all right, Lucy. Get it cleared up. You okay? I'm okay. You sure? Come see me at the end of the lesson. We'll have a chat. Fine.
What's wrong with you?
I'm just tired.
It's last lesson. Get this over with in its own time.
Okay.
A 3. Jacob, what are you doing? It's gone all over the sheet.
It's all right, Lucy. Get it cleared up. You okay? I'm okay. You sure?
You write it down this time. What's wrong with you?
I'm just tired.
It's last lesson. Get this over with in its own time.
Okay.
A 3. Jacob, what are you doing? It's gone all over the sheet.
Okay, Dr. Barnali, you can start.
Yes.
Describe the scene.
In this video, I see two teenagers, one boy and a girl, probably in a setting of a school class. It looks like a science class setting because they are using some scientific instruments.
Okay.
And both the boy and the girl have specs, and suddenly the boy, who looks a bit tired before, followed by an episode of sudden loss of tone of the body, as evidenced by falling of the specs and the falling of this container containing the liquid over his books. He spills the liquid over his books, and there is followed by return to his original self.
Okay.
And teacher comes and inquires about the incident.
Okay. So tell your what history you want to take in this patient.
I want to know whether this is the first episode, whether this has occurred before as well, particularly whether it has occurred in early morning period during the time of breakfast, whether suddenly his spoons and forks might have fallen off, and
Okay.
whether whether there was any history of any medication taken after consultation with the doctor.
Okay.
And what was it triggered by any, does it get triggered by any episodes, and what does he feel up after those episodes?
Okay, triggers. And also you have to tell about the description of the episode before, during and after.
Okay.
Okay, then after history, what else?
After history, I would like to do a full, I would like to take the vitals and a full neurological examination of the child. And also
in neurological, what you will check for mainly?
Neurological, mainly the motor system.
Yeah.
And as well as the cranial nerves.
Okay. Any weakness, any weakness, any sensation problems, any gait abnormalities? Okay, any vision problems, all
Vision
these.
problem, yes,
Okay,
yes.
then
After the examination, we would like to go for investigation. It looks like
differential diagnosis.
a differential, considering the age and the nature of his nature of this sudden falling myoclonic episode. It looks like a juvenile myoclonic epilepsy.
Okay.
And
Juvenile
or it may be second differential, may be an atonic seizure, and third differential might be a juvenile absence epilepsy, but I will consider it the last because there was no typical absence features as such.
Okay, no problem. 3 are more than enough for us. So go for your investigations and management in this case.
For investigating a routine examination, we can do for routine blood counts, full blood counts. We can look for some electrolyte abnormalities, including blood sugars and calcium, potassium, and other electrolytes. And so if we consider it as a case of juvenile myoclonic epilepsy, I would consider for an EEG.
Okay.
And also, I would like to involve my consultant regarding further management.
Okay. So any other, does this comes under primary epilepsies? Juvenile myoclonic. When do you consider this under primary epilepsy?
Because if there is no, because it was an unprovoked seizure.
Okay. Is myoclonic epilepsy comes under generalized seizures?
Myoclonic, yes, it comes under generalized seizures.
So do you want to consider here the CT brain or no?
CT brain, no, I won't do any imaging for the child.
As long as your examination is normal, apart from this epileptic presentation, he has no focal neurological deficit and he is fine in between the episodes, and you don't see any features of focal epilepsy, okay, you will not consider. Okay, so this will come under primary epilepsy. Okay, so your main here will be EEG. And what is the multidisciplinary team here you want to involve?
But the multidisciplinary team will be the general pediatrician, the neurologist, the epilepsy nurse, and mainly these 3 professionals.
Okay, what about the developmental team and developmental assessment?
From the video, it looks like child looks to be developmentally normal, but yes, we can do a formal developmental assessment, and if required, we can.
Okay, so if this is asked to you, you can tell that from the video he is looking fine as you told. And you can also say that since it is going with the primary epilepsy, to start with, I will involve my consultant and consider anti-epileptic medications. But if there is any developmental delay, or he has any means genetic problems or any other focal neurological deficits, then I will consider an CT brain or MRI, and I will consider referral to the specialist like this. From the video, you will take him as the primary epilepsy, but at the same time, you have not examined the child, right? So you don't know. From the video, yes, by speaking, you don't think he's developmentally delayed. His speech is good. He was speaking well, right? And also looks to be good height, even though he's sitting, looks to be well developed. So it can be a simple primary epilepsy, but at the same time, you have to do a complete examination. Depending upon your examination, you will consider whether he needs CT or MRI, and also whether he needs this. Okay, what advice you want to give him? Any advices you want to give him or to the parents?
Yes, there are certain advices I would like to give him. First of all, if he likes to do, first of all, there should be some modifications in the house. The edges of the beds and the chairs, tables, they should be taken care of, because if he suddenly falls off, there might be injury. Then while if he walks in the kitchen, there might be provision so that he might not get burned himself. So this heating appliances should be kept far away. Then if he likes to go for swimming, he should be advised to swim only under the care of someone. And also he should not swim very deep into the swimming pool, but nearer to the edge, nearer to the surface. And also he should take showers instead of baths. And also if he likes to do cycling, he should use pavements instead of the main roads.
Okay.
And
what about
yeah,
when he does cycling, he should also wear a
helmet.
Yeah, helmet, very important.
And and also if he is given medications, he should be there should be strict compliance to the medications.
This is more important. Compliance with teenagers is a big problem. Yes, compliance should be advised. And also if there is any transition to the clinic, that has to be advised to them. Means as they grow, you will slowly transfer them, right? And then
Yes.
they may have this problem, driving license issues. All those things will also be there when they get transition into the adult age, more than 18 years.
Also the guidance regarding careers, because there are certain careers will be a little bit difficult for him, such as pilots and certain professionals. So this can be counseled. And these are all the advices.
Okay, let's see from the guidelines if anything we missed or anything. So here, juvenile myoclonic epilepsy usually presents between the age of 12 and 18 years. Myoclonic jerks, we saw clearly the jerks he had. He suddenly was falling down and even his spectacles fall down and he spilled. Myoclonic jerks are the hallmark of this syndrome. Jerks after awakening. Usually they will have after awakening myoclonic jerks, common and often go unrecognized. The myoclonic jerks after awakening, they are common and they can go unrecognized. 90% of children with this condition have generalized seizures at some stage. So they are now in the myoclonic jerks, they can later go into generalized seizures. 15 to 30% of children with this condition will have absences as well. So the differentials you put here was the myoclonic. Then because of the falling down like that, you also considered atonic, but it was not very clear atonic. So it was a second, and also absence with myoclonic. There was a comment in this that for the MRI, it's written myoclonic seizures, but is it all the juvenile myoclonic also they go for MRI? Here it's written, this is what she was telling, myoclonic epilepsy, but I'm not sure. Go back and check for juvenile myoclonic epilepsy, which will be a continuation of absence, or which might later go into this, we will go or not, because here myoclonic epilepsy is also written under general. If anyone wants to comment, can give us a comment.
I think, Dr. Nur Fatima, if it's like, if it is really benign, juvenile benign epilepsy or myoclonic, just like kind of benign entity, not only because there is, we are afraid that they will become entity of progressive myoclonic epilepsy, which is there is another differential for it. which is became like neurometabolic, mitochondrial, and these bad type of things. In this way, it will become like really indicative to do brain imaging to catch your patient earlier. But if it is like kind of benign, the behavior of the seizure it will show up in your follow-up as benign. Likely, the patient he will be having like fair control, and if every other setting was set nicely, the compliance and removal of triggers and these things, so that means you are okay. But if he started to behave like in non-benign matter, so it might be indicative really to go for.
Okay, so we can tell that as we can tell that we will have a consultation with our consultant and the neurologist for this.
Yeah,
Is a benign and clear, because in our child, clinically here, he was developmentally normal, speaking well, looks normally developed, and immediately after the episode, he recovered. It's fine. He was going with a typical juvenile myoclonic epilepsy. But in this stage, we can describe he's going like that, but still he may have some problems. So we need to evaluate and refer to our consultant and the neurologist to consider if he needs MRI.
Sure.
Actually, here we need history because myoclonic is not a single entity. Benign, okay, isolated, but they are presented in some of the neurocutaneous syndrome. They are presented with the measles post panencephalitis. There are stages 4, 5 stages. In one of them, there is myoclonic also, one of the figure entity. So we need a history that will tell us. And
yeah, history examination, and also when you have any doubt, you will refer to the specialist referral.
And especially as we have mentioned, less than 2-year age, because in some children, some infants the myoclonics are very difficult to control. Maybe they are progression of some neurocutaneous syndrome, but they are not obvious at that time. So we need MRI at that time. Or even this measles, we don't know the measles, but there is a subacute sclerosing panencephalitis. There is stage 2 or 3. They develop myoclonic seizure. So where we need indication for MRI. So
doctor, one more thing I want to ask. For metabolic, which metabolic condition can lead to the this myoclonic epilepsy?
That one commonly in progressive myoclonic epilepsy, there is differential for it also. So like there is mitochondrial one of the differential, and there is what we call it like Mrcpch, and there is list of differential. Actually, I'm not remembering it all.
No problem. You can just take a picture and post later in the group.
Okay.
Are you in one of my groups? You are in one of my groups or no?
Noor Fatima, no. I think I'm not quite sure, wallahi, really. But I think we met together once time, maybe in a
Yeah. No problem. I will message you. Okay, so we will now just take a short break, and we still have 3 videos to continue. Okay, so after the break.
Dr. Noor Fatma, last question from my side. Like transition to the clinic, you told us, like what is the difficulties can they encounter from transition to the adult clinic?
Transition to adult clinic, usually you want to know how they transit. What is your question?
Yes, how for the transition, like how to for the transition. What I know that you have to counsel says that from the age of 12 years, and there should be proper documentation for the future planning, for the planning of the treatment of modalities. That as far as my knowledge, I know that.
Yeah, usually what happens, this is the pediatric clinic they will be following. Okay, this is the adult clinic. Okay, now this is the transition clinic. So here to start with, when they start the sessions, both the pediatrician and adult doctor will be together. Okay, so what happens, they both together will see the patient in one clinic. So
Okay.
that the pediatrician will be knowing everything about the patient till now he has followed in his files, and the adult doctor, that means he will see the child, and also he will introduce the child and the parents with the adult doctor so that they may get familiar. Okay. And also like giving like the handover, but it will not happen in one session bus. They may take a series of sessions, or depending upon, also there are many factors. Not every child of same age will be sent for transition. Some children may be they may have transition early, some children they may have transition late, depending upon how the doctors feel whether the child is mature enough to go over there. Okay. And some can go early and some can go late.
Because
yeah.
in terms of transition, you told about the driving issue and licensing. So
Yeah, that will be in the adults. I think more than 18 years, not here, right? I don't know about the UK. Maybe 16 they are giving learning license. I am not sure about the age. Most of the countries by 16 they can have learning license, and by 18 they can drive. But I am not sure about UK. If someone is here, can tell us or go back and read about it. And also transition clinics also, there is age. When you will start. I forgot the leaflet, I have to go through again. And also not every child will be you will do at the same time. You will see how mature they are, how well they can take the things, and based on that they will be transferred by counseling in the same clinic with the same pediatrician and the adult doctor together. Okay.
What's wrong now?
My mum's forgot I've got football tonight.
And?
Nothing. It doesn't matter.
So you say, oh, I don't believe it. And nothing.
Don't be so nosy.
You asked you to join in. Mum's forgot my kit again.
Come on, lads, get a move on.
So I've got no kit.
It's all right. There'll be something in the cupboard you can use.
You can wear those red shorts again, like.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he going to be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay? Me and Andy are just going to sit here for 5 minutes. You okay? Yeah? You'll be fine.
Emily?
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he going to be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay?
You asked you to join in. Mum's forgot my kit again.
Come on, lads, get a move on.
So I've got no kit.
It's all right. There'll be something in the cupboard you can use.
You can wear those red shorts again, like.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is he going to be okay?
Okay, is it
Yeah, he's
clear
fine.
to you now?
You two go and join Miss Macon in the gym, okay?
Yes, it is.
I'm just going to sit here for 5 minutes.
Okay, I'll stop. Okay, so you can start now. Describe the scene first.
I can see 3 boys in a school setting. There's a boy with helmet, and he had abnormal body movement lasting for a few seconds by flexion of the head and almost hitting the ground.
Okay, flexion of head and trunk both. Okay.
Trunk, yeah.
What history you want to take in this patient?
The first history is I would like to ask if there's any previous history of similar condition. Why he's using an helmet, if there's any family history of epilepsy, if there's any, if he feels any aura before he started feeling that abnormal movement, any history of fever, any history of head trauma also. Is he on any particular drugs?
Okay.
That's all.
Okay. You will also ask any skin spots he has, very important. Okay, so examination you want to do for this patient?
I would like to do a neurological examination, neurodevelopmental examination, and also do the skin examination, general examination, particularly in the skin.
Okay. So what are your differential diagnoses here?
My first two differentials, because it was lasting for a few seconds, will probably be an absent seizure or myoclonic seizure.
Okay, absence or myoclonic. He was falling down. Okay, there was flexion of the neck and flexion of the body. And also I think there was flexion of limbs as well.
Okay, then also, but at that stage,
Andy? Andy?
To some extent, the
Andy,
hands
you
were
okay?
also flexing.
Yeah.
So is it gonna be okay?
Andy? Andy, you okay?
Okay, no problem. So,
So is it gonna be
what
okay?
is the investigation
he's
you
fine.
want to do?
the investigation, I will start with blood investigation, complete blood count and differentials. I would like to do electrolytes, urea and creatinine, and check if there's any abnormal electrolytes. Then I will do, if this is not the first time, then I will go for EEG. If I'm thinking maybe tuberous sclerosis, I would like to do wood lamp examination of the skin and slit lamp examination of the eyes to check for retinal sarcomas and to check other complications. Echo, abdominal ultrasound, etc. Chest X-ray also.
Okay, what about considering MRI in this patient?
Considering MRI in this patient, if this is tuberous sclerosis, then it will most likely show sclerotic tumors in the brain.
Okay, so you can say depending upon your examination and history, and if there is developmental regression or or there are skin spots or any metabolic problems or anything, then you will consider the MRI. Okay, so investigations management, how do you want to manage this case?
Management is going to be multidisciplinary. I'm going to have a community pediatrician and also going to have a neurologist. I'm also going to need occupational therapists. And then if this is tuberous sclerosis, then it will need a geneticist also. And then education and healthcare plan and social supports.
Okay. Okay, no problem. So anyone wants to give any other differentials here apart from absence and myoclonic?
It could be
This is atonic seizure, drop seizures, or can be myoclonic jerks. It can be seen in Lennox-Gastaut or Dravet syndrome.
Yeah, so I think the first differential here should be atonic, because myoclonic last video we saw, right? There is a difference here.
Yeah, differential.
He's falling like as if he doesn't has any tone. Right.
Yeah.
So this is atonic seizure. Put here atonic as top. Your other differentials are also okay. You can put myoclonic second and the third absence because it's not going with typical. Absence with myoclonic or something you can consider, no problem. Okay, someone wants to play the video again. I'll just play.
Hey, you're due to join in. Mum's forgot my kit again.
Come on, lads. Get a move on.
See, I've got no kit.
It's all right. There'll be something in the cupboard you can use.
You can wear those red shorts again, like.
Andy?
Andy? Andy? Andy, you okay? Yeah?
So is it gonna be okay?
Yeah, he's fine. You two go and join Miss Macon in the gym, okay? Me and Andy are just going to sit here for 5 minutes.
Okay.
History point here should be like onset, course, duration should be start like this. Progression, anything is increasing or decreasing, like these atonic seizures can be provoked by hyperventilation or flickering lights. So then should we take past history of similar condition, as he's already wearing this helmet. So a history of meningitis, encephalitis, stroke. Then birth history is very important. And history of learning difficulties, speech problem, developmental delay. Then the family history is very important here of similar condition or epilepsy. In the labs, we will do only EEG and can think of CT, MRI and genetic testing, and definitely video we already have.
Okay, we can go to the next now. So someone was asking about these teenagers. So epilepsy in adolescents, additional factors to be considered is the compliance, very important, and career choices, and driving, contraception and pregnancy, including pre-pregnancy counseling, and alcohol and drugs. Okay, so if it is an adolescent patient, maybe it is history or even the video. If anything is asked, compliance has to be addressed. What advice you want to give to them? Compliance you have to address, their career choices as well. In an adolescent, almost 15 years, 16 years child, if the history is given from them, and also any contraception and pregnancy related side effects, so not considering sodium valproate, and also about alcohol and drugs has to be addressed. Okay. Okay.
But I'm a grown girl, aren't I? You've got one small like you. Ow! Hey, you little geek! Have you done your LCT homework yet? I'm telling you, it's well hard. Started doing it last night, and then I started texting Eda, and I can't believe that. He's gonna be late yet again. Haley, what you looking at? Miss?
Girls, you should be in lessons.
Mrs. Taylor!
Justine, I need you to calm down. Haley? Haley, it's Miss Baxter. Just gonna get you to sit down for a minute. Let's pop into Differentials class. That's it. Justine's gonna come too, aren't you, love? That's it, love. Just pop.
Mrs. Taylor!
Justine, I need you to calm down.
Haley, what you looking at? And I can't believe that. He's gonna be late yet again. Have you done your LCT homework yet? I'm telling you, it's well hard. Started doing it last night, and then I started texting Eda, and I can't believe that. He's gonna be late yet again. Haley, what you looking at? Miss?
Girls, you should be in lessons.
Mrs. Taylor!
Justine, I need you to calm down. Haley? Haley, it's Miss Baxter. Just gonna get you to sit down for a minute. Let's pop into Differentials class. That's it. Justine's gonna come too, aren't you, love? That's it, love. Just pop in here. Have a sit down for a minute.
Okay.
Okay, I can see a girl name. Okay, I can see a girl well looking and alert. She was walking in the corridor with in the this school setting with her friend, and all of a sudden she stopped and staring blankly into the space. That was for a few seconds. there was no that was associated sudden lapse of consciousness, but there was no drop, then quickly returned to the normal level of alertness.
Mhm. Okay.
Okay.
There was one more thing, some movement in the hand.
Yeah, movements in the hand was there. Yeah.
Yes.
Yeah.
Some
Haley,
hand movements were
Haley,
there.
what you looking at?
Okay.
Okay.
So,
So here history, I would like to ask the history of uh, these events before and during and after events. After that, history of associations like any fever, headache, vomiting, or rash, and history of trauma, previous history of infections, and previous history of similar kind of illness or any medications, and the allergy, lost meal, and the family history of similar illness. And also would like, as the she's adolescent, would like to ask the history of illicit drugs or any alcohol she's taking or not.
okay. So any skin changes also you can ask.
Yeah, skin, yeah, rash, yeah.
Skin changes. Okay, so examination, what examination you want to do?
So my examination after taking history will be general physical examination, and as well as particular CNS examination, including the cranial nerves, and definitely on the general physical examination would like to see complete skin examination as well.
Okay. Okay, you can also consider eye.
Yeah,
Then,
yes.
so what is the differential diagnosis here you want to put?
So my first diagnosis will be absence seizures.
Mhm.
Okay, the second one I can think of juvenile absence epilepsy, as she is
Okay.
adolescent. And the third one differential will be daydreaming, but that can be ruled out with the history.
Okay. Do you think she has any focal partial seizure also with the absence?
Yeah, that can be a part of juvenile absence epilepsy.
Okay, this can be an absence with focal partial.
Yeah, focal partial, yeah.
Absence with focal seizure. Okay. So what is the investigations now you want to do here?
So my investigation here will be EEG, electroencephalography, MRI, though it will be normal. And as I am considering of daydreaming, that can be associated with obstructive sleep apnea. So sleep study or polysomnography will consider later on with the involvement of the consultant. And yeah, that's it. And there are focal seizures as well. So that can be considered of MRI or CT. And this is the indication.
Yes.
For the focal seizures.
Okay, along with absence, you see some focal seizures as well. Okay.
Yeah.
So in usually in a seizure case, what bedside investigations you do?
Yeah, bedside investigation is first of all blood sugar. Okay. The second one we can do the fundoscopy. And what else?
Blood pressure.
Blood pressure we can do, and oxygen saturation we can check.
So treatment.
So treatment here, first line treatment as female girl, so will be ethosuximide. Okay. And second line can think of lamotrigine, and yes, sodium valproate we cannot use in the young girls.
So who will start the treatment here?
We will involve a neurologist, our consultant pediatrician, and in management I will do some general measures like the parent education, involvement of the school authorities and school nurse, and would like to do some home amendments if necessary.
Okay, what is I think it's okay. So usually your the medication will be started by your consultant or the neurologist. So
Neurologist, yes.
you'll start with the multidisciplinary team involvement, then the first line drugs will be considered. So what is the first line drug for focal?
For the absence focal,
You told already.
this one we will consider here ethosuximide.
No, in focal they have
No,
not mentioned ethosuximide.
no. This
Ethosuximide
one
for absence.
sodium valproate.
But this she's a girl.
But she's a girl. We will not go for sodium valproate.
So you can go for lamotrigine.
Lamotrigine, yeah, lamotrigine.
What about carbamazepine?
I think carbamazepine is the first line for focal.
For focal, carbamazepine we are doing. Yeah. You are right.
No, no need to remember all the medications, but at least the first line and the first one. And for girls, what is the option? I think this much at least we have to remember. Okay. So
also probably carbamazepine is contraindicated in absence.
Yeah, this is the.
That's why we have to.
So if you are considering absence and then absence with focal, I think lamotrigine is the best choice.
Yeah.
Because here first line a group of drugs is given, not just one drug. So it depends upon what you consider. For generalized tonic clonic also they have given carbamazepine, and also for focal they have given carbamazepine. Okay, but you see for absence ethosuximide is the first. I don't know, usually they may ask maybe at least one or two first line drugs as your options. I think we should know.
Dr. Noor, can you just repeat the differential of this case?
This is actually, there is a clear features of absence, but along with that, there are some hand movements. I mean, she was doing like this on her apron or coat, something she was wearing, right? She was doing some movements on that, if you observe the video. So in that way, along with the absence features, there is also some focal epilepsy you can consider, or some myoclonic epilepsy with that. Okay. So I want to ask all, what do you categorize this as? This what is shown? Is it a focal or myoclonic? Myoclonic, you should see some clonus, but it is not seen here.
Someone mentioned already that it is the hand automatism. So it is a part of the focal epilepsy, no?
Dr. Fatima, I think she has repeated movement as she is has repeated touching or
this video.
automatism.
Okay, so this is the video. So what is these movements explained as what is shown in the video of the hand? I know that for the eyes she has staring look and she's unconscious, okay, but she did not fall down like an absence. But these hand movements, how do you describe it?
I'm telling you, it's well hard. Started doing it last night, and then I started texting her, and
these moments,
I can't believe that.
They are not like my
again. Haley, what you?
They are not like myoclonic jerks, right?
I think.
So how do you describe?
Yeah, these are not kind of jerks.
This is like automatism movement.
Someone is speaking. Wait, but your sound is very far. Can you come near and speak, please?
Yeah, if you allow me, Dr. Noor. This is in my humble.
We cannot hear you.
Dr. Khalifa, there's something problem in your mic. Please, we can't hear you. Be loud.
Am I audible now for you?
No.
You are audible, but you are very far. You're speaking from somewhere very far.
Some problem with my cell phone. I don't
Do one thing, leave and join back. You will be fine, inshallah.
Okay, good.
Okay, so someone else was speaking.
For me, this is not look like it. There is no jerks or anything. This, we can say of atypical absence seizure.
No, there is something there here in the video. This is described as focal. When do we call it
We
as
can
focal?
categorize it as automatism. This had movement.
Dr.
If
Ola,
it is so,
Dr.
it
Ola,
may be temporal lobe epilepsy.
no, if we read about atypical absence, sometimes there is this movement in the hand, the blinking of the eye, smacking of the lips. This is a generalized because it occurs in two sides of the hemisphere, but it is atypical absence. If there is movement with it, we call it atypical absence. I will take a screenshot for it and I will share it with you.
Yet again.
Okay, see this
Halo.
movement. So it is not
Last night.
coming under jerk, or it is not coming under neither tonic or clonic seizure.
Part of the absence seizure if it is atypical, but it is considered as an absence seizure.
Okay, but here in this description, here they have given it as focal. So how do you see epilepsy in school? What does a focal seizure look like? So does a focal seizure will have like this? I am not sure.
Is it like
Yeah, now we can hear you.
yeah, I don't know, but I felt it is like the focality of it. It is for me like more of suggestive of like kind of temporal lobe type of seizure, since there is like as well as like this brief tonic upward gaze. It's like in between, like it is like not very clear staring, and it is not like very clear upward uprolling of eyes, like tonic upward gaze, as well as like automatic or automatism in her hands, that giving like indicative of like more of focal type of temporal lobe type of seizure, because some those type of seizure in the temporal lobe and among their semiology, you might see the automatic movement or automatism that mostly mostly associated with the focal type of seizure. So you might find like the patient having like fumbling movement on his finger, some of them like making buttoning and unbuttoning, and yeah, kind of these things, you don't feel it like being done purposefully like under umbrella of abnormal movement, but like will be associated with the state of the abnormal movement or state of the seizure itself for the ectal phase. This is what I thought of it.
Yeah, means this was some automatic movement like this.
Yeah.
دكتورة السلام عليكم. دكتورة I agree with Dr. Muhammad. يعني this is called fumbling. If you FUMBL, fumbling means you are I know in Arabic you are touching frequently as if you are seeing the texture of your clothes.
Yes,
so
yes.
This is one of the characters.
Fumbling or fidgeting.
Fumbling of the clothes and even fingers like that. So it happened in focal.
Yeah, that's why it's written as focal there in the video, and we can read here what is explained here so that we will get to know. Also, yeah, I got your point. Along with these features of absence, staring look, and there is loss of consciousness or impaired consciousness, there was some hand movements she's having, which is not going like tonic clonic movements. It was just a movement of touching the cloths, seeing the texture of the cloths.
Yeah, this is simple partial, not complex.
No, but there is some it has affected her consciousness, right?
To some extent, yeah.
Yeah, so then whenever there is consciousness is affected, you will not categorize as simple. It will come under complex.
And even
the definition of complex epilepsy.
yeah, Dr. Noor, to pay your attention, all of us, nowadays, since 2017, I think they moved to classify the seizures, like even they didn't like mention like a simple focal or like complex. Even though for the focal, they are labeling it focal aware, focal unaware, like that, which is like let us say we were or we have been knowing that simple partial or make it like more simple for us, what we are aware of, which is generalized and focal type. And the focal in I mean, even linked to this updated guidelines written like generalized, which is and GTC. This is what is known to us also like myoclonic absence. This is all we are putting it under the umbrella of generalized, isn't it? All we are agreeing on that, isn't it? And the focal type of seizure related to any kind of lobes, we have been told that the focal, which is like simple partial and complex partial. Simple and partial, partial, it means related to any kind of focality or lobe, and the partial and the complex related at the complexity of loss of consciousness. So if it is your consciousness not really, if it is like partially lost, or sometimes what they are commenting on that or verbalizing it, like the mother might tell you, this child or this is Umar, he's not himself. It is like partial loss of consciousness. This is what they are telling, and he might be with me, or he's not really communicating as he used to be. So this is like partially losing his consciousness. This is in the past, they are telling simple partial. And the complex, it means that there is a bit more so sorry not to confuse you. A complex partial, it means there is like losing his consciousness but not fully. Okay, and the simple partial, it means there is like focal seizure, any kind of focal that you have mentioned early in the definition. But simple partial, it means in the partial that it means you are maintaining your consciousness. He might be talking, walking, doing everything, and he's like not able to control the abnormal movement or feeling or whatever that he's having partially in part of his body. This is to make it like easy. And some they are telling, if it is became generalized, that the epileptic activity is generalized enough, involving the whole hemisphere, right and left, to the extent that your consciousness has been lost totally. That really, as it happened in the myoclonic, in the seizure, also it is like brief. But when it comes to the GTC or generalized tonic-clonic, that loss of consciousness generalized enough to the extent that even like in atonic, you might fall down and you might traumatize your head or your body. But this is in the past, what they are classifying it. Recently, in the past 3 years, I don't know why they are making these things, but for the focal itself, they are telling focal aware, focal unaware. What they mean by that? If it is like focal aware, that means as if they are telling simple partial. He's focal, but he's aware. His consciousness is there. And focal unaware, it means that focal and as if he is complex, focal complex, as if it is like simple simple complex. It may that is it, focal aware, focal unaware. This is what they mean. And the GTC, I think they replaced it with more of like with the patient having like generalized tonic-clonic with bilateral tonic-clonic base instead of telling like focal with secondary generalization. This is only just what I mentioned, that why you might be facing some of the examiners. They may ask you, are you aware that there is like some change, or why they are telling me in the past? But when I noticed that the new guidelines, I think the new guidelines that still we are using the same previous definition, which is simple partial, complex partial. So I suggest all of us, let us stick to the what has been written in the guideline, the previous kind of classification as Dr. Noor teach us today, and that is it. But at least to be aware that there is like some kind of new, some of the examiner, not all the examiner, you might find them just away from the update in the classification.
Okay. So now what we saw, I think mostly it is going with a focal epilepsy, that is temporal lobe epilepsy. Why? Here we will see focal seizures with impaired consciousness. Yes, there was some impaired consciousness, and complex automatism. aura common before seizure, which could be a sense of fear, abnormal abdominal distension, or any other. Okay. And the child are very tired and sleepy after episode. Children with history of prolonged febrile seizure in the early years of life may have this mesial temporal sclerosis as a cause of their seizures. Other causes can be cortical dysplasia, gliomas. So here there are tumors. That's why MRI you should do in all focal seizures, and neuroectodermal tumors. Some patients can be candidate for epilepsy surgery. So the motion what we saw in the video was this. This is a part of complex automatism, right? Hello.
Dr. Ola, I shared the link in the chat. In this link for epilepsy, it is said that the juvenile absence epilepsy, which occurs in juvenile age, it is a generalized type, not focal type, and it can be associated with movement of the hand. In the link which I shared in the chat.
Okay. You shared in group or what? Okay, so usually anyways in the exam, don't worry. They only consider your differential diagnosis. So here the staring look, she has a staring look. So you can give an absence seizure also. She has some checking the texture of the cloth movement of the hand. So it is giving you some feature of automatism here. Okay, so you can put it as focal epilepsy as well. And she has some impaired consciousness as well. So here they want you to put differential. So here you can put absence seizures or atypical absence, and also focal seizure as the differential. Okay. No problem. And then you can tell your, if it is focal seizure, definitely see some of the here gliomas and all these things are the means causes. So definitely any focal seizure is an indication for for MRI. So if you put it as focal seizure, tell MRI also in your this. And what about atypical absence? They are also doing MRI for atypical absence.
I think they do EEG, there will be generalized spikes and wave.
In atypical absence, there won't be this 3 per second spike and wave. It is for typical.
The typical will be 3 spikes, but the atypical or juvenile absence epilepsy, it is written in the guideline that it is generalized spike wave.
Yeah, you are right.
In the guideline, it is different. The EEG result in child absence epilepsy, and not as in juvenile absence. Juvenile absence, it is generalized spike and wave, but in childhood absence epilepsy, it is the focal EEG 3 per second spikes.
Yeah, so if they ask in such an question, you can always tell that I will examine the child. If there is any developmental problems associated with the child or any focal neurological deficits or anything suggesting me to go for MRI, we will go involving the consultant and the neurologist like this. Okay. If any answer confuses us, we can tell like that. So we will have one more video and then we will finish our session.
Yes, and someone's with her now. Okay, no problem. See you shortly. Thanks. Goodbye. Is everything all right? Yeah, she's just sleeping. I'll be next to her if you need me. Okay, Kelly. I'm just going to put you onto your side. It's going to be okay.
okay? You just lie here and have a rest. I'll be next door if you need me.
Okay, we can start now.
Okay. I saw two ladies and one girl in a one room. Most probably this is an office setting. The girl is wearing the uniform. Then suddenly I noticed sudden onset of uprolling of eye and the tonic contraction of whole body, mostly involving the upper limbs and the lower limbs. With the mother is aware of that episode, so she started immediately noticing that time duration of that illness, that episode of fit.
Okay, then what she did?
After that, she make the child on the left lateral position.
Yes, okay. So what is the history you want to take in this case?
On that case, in this case, the same is I would like to take the history of the onset, duration, and the progress, previous history of the similar episode, and I would like to take the history of previous on if the child is on any medication, history of trauma, any neurological regression, developmental. I will like to take the history, developmental history. I will take the family history, and I will take the history of any rashes in terms of the neurocutaneous syndromes.
Okay, you did not tell about tumor. Any history related to tumors you want to ask?
Yes, definitely, and history of fever and rashes, and yes, any school deterioration, the school performance also. Yes, definitely.
Headache,
Headache,
vomiting, behavioral issues, and eye problem, eye difficult.
yes.
Okay.
Headaches, yes, you're right. Yes.
Then
after that,
examination. Give me the examination. What
I will do the
Hmm.
yes, I will do the examination. I will take the vitals. I will take the blood pressure. I will check the saturation. I will check the heart rate also, respiratory rate, and I will do the fundoscopy, cranial nerve examination. I will check the gait. I will do the complete CNS examination along with the general physical examination in view of the neurocutaneous syndromes.
Okay, and also developmental assessment.
And development assessment as well. Yes.
Okay, then
after that, I will do the
diagnosis.
For my diagnosis, I will just do the EEG to confirm my diagnosis. I will perform the EEG.
Okay.
And MRI brain in cases if it in cases if it is not going to not going to respond to my treatment of the anti-epileptic drugs after 2 years, then only, or any developmental regression, speech regression, then only I'm going to perform the MRI brain.
Okay, so what is the team you want to involve and how do you manage this case?
For my management perspective, as I already take the history and I'll perform the investigation. First of all, I'll consult the parents about the disease itself, what lifestyle modification they have to perform at home, and what activities she can perform. I will counsel in detail about that. Then after that, I will involve my consultant for the start of the anti-epileptic medicines.
Okay.
Beside that, yes, anti-epileptic medications. That's all. In my multidisciplinary team, it is the community pediatrician, it is the neurologist, it is a epilepsy nurse, and the social worker as per my history requirement. Then I will see.
Okay, when do you want to consider if you want to refer this patient to the tertiary center?
At any point, I will notice that there is a behavior problem and any syndrome that I could not able to identify, or any regression, as I told you, regression in the milestones, or my treatment is for more than 2 years and no response. Some other So in that case, I'm going to involve the neurologist or refer to the tertiary center.
Interactable seizures as well.
Yes, interactable seizures.
More than 2 drugs and you tried and still they are not responding to you. And also any neurocutaneous syndromes.
Okay.
Will refer. Okay. And also MRI you will consider here. They will come under generalized seizures only, tonic, as long as the child's examination is normal. Apart from the seizures, I don't think you'll consider. Otherwise, there has to be, as you said, behavioral changes. Maybe you on your examination, there is increased intracranial hypertension, or there is no control of seizures despite you have given first line medications, or any neurological deficits, or the child was fine, sudden onset of neurological signs, all these things. Otherwise, routinely, in a simple case with no side effects, means the child is normal, your examination is completely normal, including fundoscopy, apart from the seizure, and EEG is going with it, and I think no need. I just want to ask before any comments for this, what in this case you will go unless there is any complication for MRI.
Any complication?
Can you repeat the video again, please?
Okay, sure, I will show you.
Doctor, I want to ask the differential diagnosis. It is a generalized tonic epilepsy, na?
Yeah,
What
it's
would
very clear, it's tonic, means there is no clonic here. Means if it was
no tonic, yeah.
It was very clear tonic, but you can say and negate it that tonic clonic, but I don't see any clonic features here. And also you can say, but myoclonic also we cannot say, it's not just in one part, and there is no involvement of clonus. So I think
dystonia we can put here.
What?
Yes,
Dystonia.
Okay, yeah, dystonia. What else?
It will be generalized tonic clonic, generalized tonic clonic, or this dystonia.
And also we can also put the sometimes pseudo seizures also if we don't get anything. If there is
Yes.
a trigger with fall, emotions or something, they can do like this, just stretching their hands, looking upwards. Okay. You can also put pseudo seizure also if you don't get anything. You know, some children, they do like that if they are angry and if emotionally upset, or fought with, especially the teenagers fought with someone at home, they can do like this. And they can also do like the tonic clonic ones also, looking upstairs, continuously moving their hands like that also, you know. I have seen like that. So pseudo seizures can also be your differential here. Okay, you wanted to play the video again, I will play.
She looked up, so we've let her have a lie down. Care plan, and someone's with. Is everything all right? Yeah, she's just sleeping. I'll be next to her if you need me. Okay, Kelly. I'm just going
You
to
can
put you onto
also
your
observe,
side.
if you observe in the video, she also has skin spots on her face, if you can observe. You see, there are some spots on her face. Okay, all these comments becomes important.
Okay, Kelly.
Okay, is it enough, the video? Okay, So I think we done. Only all of us will remember some common points to be asked in all epilepsy cases. So first describe the scene, and whatever you see, whether it is tonic, clonic, or just tonic, or just myoclonic, or absence, or atypical absence. Okay. Whatever you see, you will just describe, and also the scene. And if they did something like the patient aborted from the seizure and they put the patient on left lateral position and they gave some support under the head or under the neck, and any danger things around the patient you will remove. So what is the first aid you will give? Any danger things around the patient will be removed. As soon as he is in post-ictal state, you will try to extend the neck, give support to the head, and that means open the airway, put in left lateral position, right? So whatever you see in the video, describe it. Then in the history, always don't forget, describe whatever the scene you're seeing. So you will ask for onset, progression of the seizure, and duration of the seizure also. So for the seizure attack itself, any triggers before, what was the child doing before that, or any feeling of aura the child had. And then you will ask for how did it started, onset, progression, and how did it end. Okay, after onset, progression, and how did it end, you will ask for the duration. Usually how many seconds it lasts. Does it last for 30 seconds? Does it last for 1 minute, or whatever, if the parents have noted. So after all these questions, you will have some different, and you can always ask due to the falling down, the child had any trauma, okay, during this time. Then always keep your differentials in your mind. So tumor is one of the differential, trauma is one of the differential, infections. You have to rule out neurocutaneous syndromes. So any skin spots can be used. They may have metabolic conditions. So any chronic condition the child has and is on treatment. And they can have what else we have to ask about the drugs, and also the developmental history. Is he normally developing according to the peers, or do they have any problems? And for tumors particularly, you will ask for headache, vomiting, behavioral change, headache and early morning vomiting, and behavioral changes, and any blurring of vision or eye problems. Okay, this will be for the tumors. And also for the trauma, you'll ask any history of head trauma. For the infection, you will ask any history of fever, which is very high grade fever. And also these signs of increased intracranial tension you will be covering here. Okay, any point I missed, important points in this station? If I missed something, you can add. Okay.
Yes, that's fine. Very good.
No, I did not miss anything, alhamdulillah. Okay. This is the history here. So then in the examination, when you tell CNS, just don't stop there. Just tell what do you want to look in the CNS. So any, you want to look for the gait. Tell few points, important points. You want to look for the gait of the child. You want to look for weakness in any part of the body, or loss of sensation in any part of the body. You want to look for the vision. You want to do the fundoscopy. Some 3 or 4 points you tell what do you want to look exactly in the CNS, which is helping your examination. And you will never forget for the skin examination to rule out any neurocutaneous disorders and the developmental assessment of the child. Okay, and in any case, if you put syncope or something as your differential, you can also say CVS examination. Okay, just in case. Otherwise, your CNS examination and skin examination and developmental assessment is very important here. Okay, and if you are suspecting infection, you can also tell about the source of infection you are suspecting, no problem. But this 3 is very important. Then your differential diagnosis. Differential diagnosis, like for the last video, it is very clear. So what is clear to you? Put it first. So the first video we saw today was tonic clonic seizure. Okay. The second video we saw was the absence. So related to the absence, you can put anything like daydreaming. Okay. And also sometimes they can have myoclonic, so atypical absences, but here I don't see any myoclonic features like this. Okay. And there's someone said also selective mutism for absence, but at the same time you have to tell the child was playing very well, so it doesn't go with it. Okay. Then for the tonic seizures also, if you say tonic and also generalized clonic or pseudo seizures, just say that negate your point. Like, I don't think in pseudo seizures the child will have postictal phase or something. Okay. Like this, whatever you see based on that, just keep at least 3 differentials to tell at least. And also the one will be your top of the differentials, the other 2 tell why you are not considering it. Then after the differentials, we will go for investigations. Okay. So in any seizure case, remember, if it has come to you as an emergency, so the bedside, important, you will start with the blood glucose, then you will blood pressure, or you can say the complete vital signs, including blood pressure and fundoscopy. Okay, fundoscopy to see the features of raised intracranial hypertension. This will be your blood side, bedside. So for the diagnostic of any epilepsy, EEG will help you. Most of the primary epilepsies, along with the clinical features, EEG will help you. Okay. Then MRI, when do you consider? Not all epilepsies. When apart from the seizure episode, the child is growing normal, there is no concerns about development, and there is no focal neurological deficit. So most of the primary epilepsies, you will not consider MRI. So always when you want this indication is asked, tell if on my examination, if I see that the child has the child is developmentally delayed, or there are features of neurocutaneous syndromes, or there is what else? A focal neurological deficit, weakness, sensory loss, or anything you feel, facial weakness, at that time you'll consider. Otherwise, you will involve the consultant and neurologist to take the decision. Normally, not every epilepsy you will start doing MRI. So when do you refer to tertiary center? Read it and keep it in your mind. This can be asked. And multidisciplinary team. So always many of the primary epilepsies can be managed by your consultant itself without referring. So first you will involve your consultant for starting of any drug. Then in any case, neurologist is needed. Then the teenagers can have psychological problems, school problems. So psychologist, child psychiatrist will come into play. Entire developmental team, depending upon if the child has developmental delay. If the child has metabolic problems, the metabolic team will come here. If the child has tumors, the neurosurgeon can come. So you can list and you can tell this. Okay. So like this, and along and investigation, some important I left always CBC and urea and electrolytes and other electrolytes like calcium, phosphorus. So you can say bone profile as well, or calcium, phosphorus, magnesium is very important along with sodium and potassium. And if any cardiac condition you are thinking of, you can consider ECG as well, very rarely. Okay. So like this, I think in 6 minutes, you should cover at least this much, and you should know when you consider MRI and when you refer the patient. Okay. So anyone wants to add anything before we end the meeting? Can tell me. Maybe even I would have missed some points. So read the guidelines again, make your own notes so that any seizure case comes, how you can answer. So for all these common seizures. Now the missed part here is the status epilepticus, for which you can watch one video on status epilepticus and read from the guidelines, the management. Okay. Otherwise, I think most of the seizures we covered. So all these videos, some are asking me for the videos. All these videos are available on the YouTube. Just go to Epilepsy in School. Put it. It is from the UK, all these videos. You will see all these 6 videos under the website Epilepsy in School. Okay.